Good afternoon. We're going to try to start promptly. I'm delighted to see that so many of you took on the weather to be here. We had a little scramble this morning in that our first speaker, who was planning to be here in person, was waylaid by winds that wouldn't let her travel via ferry. And so our wonderful tech team jumped on it, and she's going to be here remotely via Zoom, and she will also be present that way for the panel. And so I'm just really excited that you're all here for this forum in which we're going to explore your rights and limitations under Washington state law to determine and communicate your end-of-life wishes. My name is Marcia Limoges, and I'm a member of the Healthcare Committee for the League of Women Voters of Clallam County. The League is a national, nonpartisan organization whose purpose is to promote the informed and active participation of citizens in government. Both men and women are welcome as members. Life and death are words that are often used in the same sentence, yet we don't tend to focus on death as we go about the business of living. We focus on gaining the knowledge, skills, values, and relationships that support a meaningful life. As we mature, it is wise to focus on gaining the knowledge and skills to communicate with our loved ones and our medical providers regarding our values and wishes about the end of life. And with this as an objective, the first half of our program will be presented by Cassa Sutherland remotely, but you will see her face and her entire presentation here on the screen. She's the Client Services Manager for End of Life Washington. We do ask that you please silence your cell phones and be aware that this program is being video recorded. It will be available for later viewing on the League of Women Voters of Clallam County's website. There will be a very brief break while they transition from the first half to setting up some chairs and tables for our panel for the second half of our program. And you were given some index cards, which you may use if you like to record or write down questions and then hand them to a volunteer at a later point when they'll come around to collect them. Questions will be also accepted at the microphones. We will have a volunteer at each aisle with a mic if you prefer to ask a question live in person. And we do ask that you please try to make your questions clear and to the point, taking less than 1 minute at the microphone. The panel discussion, question and answer portion will be moderated by our league member and retired public health nurse, Norma Turner. We thank each of our panelists who are here for their generosity in sharing their time and expertise with us. And we welcome Cassandra remotely at this time. I hope we're all ready to go.
I hope so too. Thank you for that lovely introduction. I'm hoping you can all hear me and hopefully see me at this point. My name is Cassa Sutherland. I was really looking forward to being with you all in person. Unfortunately, I couldn't make it, but I am glad that in the world we live in, this is an option. I am the Client Services Manager for End of Life Washington. I've worked for the organization for about 3 years now. I got into end of life care back in 2015. My father was diagnosed with dementia, and he really wanted other options for his end of life. He did not want to live to the end stages of the dementia disease, and put me on the case to figure out what his options were in Washington and what he could legally do, and that was really important to him. He ended up voluntarily stopping eating and drinking in 2017. I did my master's in public health on voluntarily stopping eating and drinking, something we'll talk about in this presentation, traveled to the Netherlands some, and then when this job became available, End of Life Washington, really felt like this was my spot to land. Today's presentation is going to be split up into two main parts. We're going to spend the first part talking about documentation and planning. So what is it that you need to have your advanced care planning in place in the case of a disease or illness or a lack of capacity at some point? And then the second half of the presentation, we'll talk more in depth about what are some of your options in Washington and what are some of your limitations in Washington. The PowerPoint will be available afterwards, and I love questions and look forward to hearing what you all have. So let me see if I can move forward in my slides. Here we go. So we are going to spend today talking about death and dying, and I use those terms with meaning. We hear a lot in our culture. We live in a pretty death-phobic culture. We hear a lot of people say passed away, passed on, are pushing daisies. I know that death and dying can be an activating subject for many of us, and I hope to speak with some ease and grace about it, but I want you to know that I don't take it lightly, and my involvement in this work makes me live fuller and harder. And my hope is that in talking about end-of-life options and death and dying, that we can all approach it with a little less fear and a little more ease, because hopefully we can have our options honored. So I want to begin by giving you an introduction to End-of-Life Washington. End-of-Life Washington is a nonprofit in Washington. We do not get any state funding, and people often assume we do. We are 85% just private donor funded, and we work in three main areas. So the first is education and resources. So presentations like this. We do presentations to service providers across the state, to hospices. We do consulting. We have a website full of free resources, advanced directives, and all of that is available to the public. We also work in direct support. So we have 80 volunteers across the state of Washington, actually many lovely volunteers in your county alone. And these folks are the people who help folks in Washington navigate either medical aid in dying, primarily medical aid in dying, and voluntarily stopping eating and drinking. So this is the direct support for terminally ill adults in Washington that End-of-Life Washington offers. And then finally, we always are working in advocacy and public policy. And so I'll talk a little bit more about the bill that we're actually working to get passed right now in the state legislation. But we have also passed a Patient Protection Act 2 years ago. We helped pass the Death with Dignity Act law back in 2008. And so a big part of our work is always advocacy work. Okay, so when we're thinking about end-of-life options, and this is as we enter into this first part about what type of planning and prep do you need, the first thing is to really start with your values. So start with the living part, not the dying part. Start with, what does living well mean for you? How do you define your quality of life? What brings you joy? What is really important to you? Up here, you have an example of the End-of-Life Washington value sheet that you're welcome to print out and start there. We start with the living and the joy because it makes it easier for us to figure out what it is that we would want at end of life. And as we pick people to be as part of our support team, having a values worksheet makes us also realize where we might not have or agreement with those people in our support team. So for example, you might want to die at home instead of in a hospital, and that might mean foregoing some life-sustaining treatment. And so that might be something that you identify from doing a values worksheet and can start that conversation in the point of living. And then you can talk to your family or friends or support around what your values and quality of life mean to you. So I think the thing that has me most surprised in this work, and I don't know why it still surprises me, is how many people get to the end of their life or an illness or a disease or a hospitalization and haven't done the planning ahead. It is hard to do this, and it is so important because if you do a little prior planning now, you'll have a much easier time in the future. And where this really, I'm going to go through a whole bunch of documents that are available in Washington and will help you outline and support your end-of-life options. But the reality is it's often the people around you. So it's really important that you have a good support team. So this means talking to your providers, to your friends, to your family, to your people earlier rather than later, and figuring out who it is that you will want around you during this time of your life, and making sure that you're having these conversations so that everybody is on the same page. So the most important person on your support team is your healthcare agent. And so you will want to create, if you haven't already, a durable power of attorney for healthcare. This is the person that speaks for you and makes decisions for you in the event of a healthcare crisis when you cannot communicate for yourself. This could be a family member, this could be a close friend, a trusted advisor. There's also people who are hireable and will be this person for you for pay. There's lots of different ways that this can look, but it's important that you trust this person and this person is best suited to honor your wishes. So for example, we often work with clients who might have their ex-husband or ex-wife or ex-partner be their power of attorney for healthcare still. They may even be remarried, but this person, they are the chosen person for their healthcare decisions, and they know the most about their wishes in case of an emergency or when they can't communicate. And so it's important that you pick somebody that you trust, and not only that you pick them, that you tell them that you've picked them and that you've had a lot of these conversations with them already. When filling out a durable power of attorney for healthcare, you will name both a primary and a secondary person. And your durable power of attorney for healthcare is witnessed by two people, and I'll go a little bit more into that, or notarized. And that is the most important first decision you'll make when it comes to end-of-life options and planning and prep. So then you will have this healthcare agent, and to support this healthcare agent, you'll do a healthcare directive. There are many versions of a healthcare directive, but basically this lays out what you want in terms of your end-of-life wishes. It puts it down in writing of, in case of this, I think I would want this. In case of this, I want this or don't want this. This really helps your healthcare agent if there's something that comes up that you haven't talked about that is in your healthcare directive that they can refer to or can help them make decisions. There also are sometimes scenarios that aren't addressed in these healthcare directives that you might want to have addressed. And so you can always add an addendum in your own writing about your own end-of-life care and what you would like to see, and that can become part of your Living Well or healthcare directive. It's really important that these healthcare directives are shared, again, with your healthcare agent, but then also your providers. Often people have them on file in different places. So it's important that people, not only do you have this document, that it is easily accessible for folks. So your healthcare agent and your healthcare directive get combined into one that we call the Advanced Directive or your Living Will. And there are many versions of this out there. End of Life has one called the Instructions for Advanced Directive. Honoring Choices also has one. 5 Wishes also has one. It doesn't matter which one you use. You just need to have one. And it is the most recently signed, witnessed, or notarized is the one that will be referred to. And so you don't have to do them all. You just have to pick one and do that one. We have them available at the End of Life Washington website, and you also can get them off Honoring Choices. Honoring Choices has theirs translated into 15 different languages, which is a very nice advantage. And if you're looking for a language other than English at this point. Sorry, my slides are a little slow here. So not only do you fill it out, you get it validated in Washington. That's either 2 witnesses that are not related by either blood or marriage or part of your state or your healthcare providers, or you can go get it notarized. You need to share and make it accessible. You want to update it as needed. And not all advanced directives are applicable in all states. So if you're moving or changing states or countries, you want to evaluate if your healthcare directive still stands, and you only need one of these. I really recommend that you fill these out you share it with your healthcare agent, you save your healthcare agent in your phone as such. You take this document to your providers and share it with them and make sure that they know who your healthcare agent is. It's important that, again, these papers are only as good as the communication you have around them and who you have shared them with. Okay, so then in addition to the advanced directive, which is your general healthcare directive, you also have some additional directives that are optional. End of Life Washington developed a directive about living with dementia, and it's a mental health care directive that goes through different dementia scenarios when somebody loses capacity. And so this is a great document and additional directives that can guide dementia care, as well as my instructions for oral feeding and drinking, which allows somebody to stop being offered food or water at a certain point in their disease. Both of these directives will only allow somebody to stop eating and drinking if the person isn't asking for it. But the moment you ask for food and nutrition in these directives, you will be given it. And these aren't the only dementia directives out there. There are other ones, but this is a great place to start if you think that dementia is something you might be facing or are concerned about and want to think about how you'd want your care managed and want your healthcare agent to help with those decisions. These directives are filled out when somebody still has capacity, with the expectation that in the course of their dementia, they will lose capacity, and that these directives will help guide those decisions that are made about their care. It goes through things about finances, about where they might want to get care, many different scenarios that are common in a dementia or Alzheimer's diagnosis. So switching gears, we also have Pulse, and these are, it's the portable order for life-sustaining treatment. Often people think of these as the kind of Washington State DNR equivalent. So this is only needed in the instance of a diagnosis of serious illness or an end stage of life. Some people over a certain age threshold also talk to their physicians and have a pulse on form if they don't want any life-sustaining treatments. These are conversations about, do you want a full code resuscitation and CPR? Would you like comfort measures only? Do you want to be treated with antibiotics or not? And then these decisions are made with you and your physician and then signed by your physician. In order for it to be valid, it has to be signed by a physician. And these are the forms that that EMS looks for in responding to an emergency. So if you do have a pulse, we recommend, you'll see them sometimes posted outside on people's doors, in fact, but really on the fridge as well is a place that people in EMS is trained to look for these pulse forms if responding to an emergency at wherever you live. So to go through kind of the flow chart of it, all adults, regardless of age, want to complete an advanced directive. So that's both your healthcare directive and your power of attorney for healthcare decisions. And you update those as needed. So I recently went through some transitions in my life. And so I also updated my DPOA and named a new healthcare agent. And so I have now an updated document, and that should continue. And we don't know when disease and illness will strike. And so we want everybody, every adult in Washington to have one of these. And then you kind of get to decide if you evaluate the need for a pulse. If you're living with a serious illness, you're over the age of 70, at that point, you can evaluate with your physician or yourself if you want that pulse. And then that is how you have your end of life wishes well documented. So you want to start with your support team. I recommend starting talking to your physicians, your care providers, your healthcare agent, friends, loved ones. Some people hire doulas, any type of support to talk about what your values are, what you want at end of life, what kind of options you are interested in. You want to complete an advanced directive, so both that healthcare directive and DPOA. You want to evaluate the need for a pulse for yourself or for others. You want to discuss and provide copies of that advance directive to your support team. And you want to talk about your end of life wishes to all of those that care for you so they're prepared and aware of your choices. All right, so we're gonna transition from the options and planning a little bit more into what are some of the legal options in Washington once you've done your planning and prep. I also, at the end of this presentation, have some other resources that you can go to. When it comes to doing your advanced care planning, I often find that people have well-intentioned meaning to get to that paperwork, but it continually gathers dust or piles up on desks. And so there are some groups in Washington. I've seen people create like advanced directive accountability buddies or groups where they fill them out together and talk about the different options in the advanced directive so they can get a clearer understanding of the options. There also are options to go to advanced directive workshops in Washington where you can work on your advanced directives in groups. And so some of those resources I will also share at the end of this presentation because I understand that doing them is often the hardest part. All right, so as we transition into the second part of this presentation, we're going to talk a little bit more about options and choices in Washington around serious illness and disease. I do want to say and start with, you always have the option to accept or refuse treatment. We live in a medical culture that often isn't the most, we live in a culture of medicine that we want to solve and cure and make better, which we are so grateful for. And I appreciate modern medicine so much. And it sometimes physicians don't always give the option of that you don't have to take every treatment they offer you, and you can choose to stop treatment at any time, and that healthcare advocacy and how you advocate for your own needs and wants in medical care is really important and makes a huge difference in what type of care you get. And I think a good death is one that has come after a good life. And so we want you to get all of the care that you want and desire, and know that you can always accept or refuse care as well. So there are palliative care and then hospice care. So palliative and hospice care can be in place to reduce any discomfort you might be experiencing from an illness. Palliative care is often offered at any stage in the disease. It's the same as curative treatment. It's paid by for most insurances. It can happen simultaneously along all the other care you get. So for example, somebody who maybe has been in a traumatic car accident might get palliative care to help with their discomfort that they're experiencing as they recover. And then once they are finished with that recovery, they no longer are receiving palliative care. Hospice care, on the other hand, is a very end of life stage of care. It is when somebody stops or is no longer receiving curative treatment, and they've been given a prognosis of 6 months or less. This is paid by Medicaid and Medicare. It often happens at home, and it includes a ton of resources for the support team as well as the person on hospice care. And it offers complex symptom relief and is an amazing resource for folks who are at the end stages of their lives. And 95% of people who do medical aid in dying in Washington are also on hospice. And hospice care is often looked at as one of the precursors or parts of qualifying for medical aid in dying in Washington, and something I'll talk about as we get through there a bit more. So you in Washington have the option to hasten death, to end your suffering and die on your own terms. These are choices that only an individual can make. They're not options considered by everyone. We all have very different cultural, spiritual, and philosophical beliefs at end of life. And these are options that Washington State has made available for those folks who do want to die on their terms. At End of Life Washington, we want to introduce you to all the options, and I will support whatever option you choose wholeheartedly. One of my favorite clients are those clients who get access to medical aid and dying meds and then tell me, goodness, just knowing I have this option reduces my suffering so much. And I'm so excited to keep living. And they go and have their suffering reduced by having this as a choice and never use the meds at the end of their life. In fact, people who access medical aid and dying, 25% of them who get access to the medications never use them. So you always have a choice. And in Washington, we have the choice of medical aid and dying or voluntarily stopping eating and drinking. Medical aid and dying was passed in 2008. So it's an option that we've had for about 14 years now. So medical aid in dying allows someone terminally ill to control the timing of their death with medication, and it reduces anxiety, pain, and or suffering. In Washington State, you have to have 6 months or less to live to qualify for this option. You all may have heard recently that Canada has passed this in the last few years, and they have a much different interpretation of medical aid in dying, one that has more ability and ease to qualify. But in Washington and all of the nation right now, there's really strict guardrails and qualifications for who qualifies for medical aid in dying. And so these are people who are already dying of a terminal disease. These people who choose medical aid in dying, most of them don't want to die. They want to keep on living, but they have a disease that is killing them. And since their death is inevitable, there are people who want to choose how they die by using this medication and have some control over the timing and date of their death or to help reduce anxiety. There's very few people in Washington who actually use this as an option. Last year it was about 350 folks, and that's less than, it's about 0.3% of all total deaths in Washington are through medical aid in dying. And so it's a small subsection of people. It is growing yearly, and it's really important to these people who want this as an option. Washington State voted on this in 2008 by a voters' initiative. We passed it 51-49 at the time. Now in Washington, about 70% of voters support this as an option. However, we are still pretty behind on our interpretations of this law because it's still stuck in 2008. And the states that have come most recently and passed medical aid in dying laws have done so with laws that are have less barriers to access. And we'll talk about that a little bit more in a few minutes. So the specific requirements of the Death with Dignity Act in Washington, and I want to make a small note here, is that in Washington, we passed our law calling it the Death with Dignity Act, and you'll hear it referred to most often as Death with Dignity. I like, and the trend in the nation is to call these types of aid in dying work medical aid in dying. And the reason being is that there are many ways to die with dignity. And using the Death with Dignity Act does not make your death more dignified than somebody else's and their choices. And so I don't particularly like that it's called the Death with Dignity Act. And that is something I would like us to change at some point in Washington. And since Washington passed their law, the other states that have since had a medical aid in dying law have called it things like the End of Life Options Act, for example. To qualify for medical aid in dying, you have to have a terminal illness with less than 6 months to live. You have to be a resident of Washington State. You have to be 18 years or older. You have to be capable of self-administering. You have to have 2 doctors who can and will support death with dignity, and you have to have decision-making capacity. So I want to go over just slightly the ones on the left here, or on the right-hand side of the screen. So capable of self-administering is a really important part of this law. The law is super clear that the person doing this has to be able to administer their meds by themselves. So this often looks like swallowing 2 to 3 ounces of this medication. It could be out of a straw or just drinking it out of a cup, but nobody can help you do that. You have to self-administer. We also see rectal administration in Washington, or these medications can be really ingested anywhere in the digestive tract. Unfortunately, this leaves out folks who, or can potentially eliminate folks who have neurodegenerative diseases and lose the ability to swallow or lose the capability of self-administering. There's actually a lawsuit in California around this right now. You also need 2 physicians who can and will support medical aid in dying. And this is really hard in Washington, to be honest. We have a lot of restrictive healthcare. 50% of our hospital beds are religiously restricted. And so we have a lot of physicians who can't support medical aid in dying because of where they work, or where they work isn't restrictive, but has policies that won't allow them to support medical aid in dying. I really want, if you're in this audience, for you to talk to your physician if you want this as an option, and find out early what their stance is on medical aid in dying, and where they work, what their policies are on medical aid in dying. You need 2 physicians, both a prescribing physician and a consulting physician. And at End of Life Washington, we will help you find physicians. We work with an amazing group of 40 to 50 volunteer physicians. These are mostly retired folks who keep their license to be able to do this work over telemedicine for all the Washingtonians who don't have physicians that can do this. I will be honest that this is not a sustainable system. End of Life Washington cannot be the nonprofit that is filling the healthcare gap for medical aid in dying in Washington. What we are working hard to do is to make systems more responsible for this type of care, because this type of care is just good palliative end of life care. It needs to be integrated into modern medicine, into hospice care, into quality of care conversations at the primary care level. And End of Life Washington can't be the stopgap for the providers. And so we're really encouraging institutions to update policies so that their providers can be both the attending and consulting physicians. And we understand that in a restrictive state like this, we will never not have a place to support Washingtonians in making sure that they have access to this law. You also need decision-making capacity. This one is also incredibly important because this one eliminates most folks with Alzheimer's or dementia. And so you have to be able to show that you have decision-making capacity about 3 different times during the medical aid in dying process. And then if you work with an End of Life Washington volunteer, they will also verify your decision-making capacity on the day of your chosen death if they are present for that. And so folks with dementia are not qualifying for medical aid in dying. And I would, on a personal level, love to see that change. And I don't see the path forward in our current climate as a nation where that becomes possible. There are other countries that are doing this, like Canada, like the Netherlands, like Switzerland. However, I do not see the United States being able to get there, hopefully by the end of my lifetime, but I am not convinced. So people who choose medical aid in dying, if you think this might be a choice you would want to make, I encourage folks to start as soon as they're eligible. So as soon as they're having those end of life conversations with their providers. One common thing you can ask is, would you be surprised if I died in the next 6 months? Is a good way, or one way to get a provider to start thinking about, am I eligible for hospice services, for end of life services, and therefore am I qualifiable for death with dignity as an option? About 30 to 40% of people who come to End of Life Washington do not make it through the process because they don't have the time to complete the waiting period. And finding physicians, going through the waiting period often takes more time than people have. And so getting through the steps so you have that ease, if you want it, is get started sooner rather than later. I said earlier that 25% of clients don't end up using the medication. And this is where our direct support mostly operates. So we offer one-on-one volunteer support available from End of Life Washington to have you walked through this process. So the volunteer will meet you in person, help find providers if that's necessary, make sure you're crossing all your T's, dotting all your I's, making sure you're making it through all 13 steps of the process. And then our End of Life Washington volunteers will be there with you on the day of death if you choose, and will be there to mix the medications for you if you choose, so that the people around you can just be there as the people around you and not in the responsibility of mixing the meds and being part of that process. We've supported folks from 18 to 104. Most folks have terminal cancer, although we're seeing more ALS, Parkinson's, COPD, heart disease, or other diseases every year. We also are seeing more and more requests. So where for years we had been increasing services by 10 to 15% a year, we in the last 2 years have seen our requests for services go up by 40 to 50% a year. We have doubled our volunteer force. We have doubled our provider force. We're working harder than ever in fundraising to meet the growing need in Washington, as more and more people want this as an option, which I think is partially because more and more people know that they have this as an option. So this is the steps of the law. So just so that you have a sense of what it looks like, you start with a first oral request, you find providers, you do a written request, you make a second oral request, and then you have a prescription that can stay at the pharmacy for 6 months. It only works with compounding pharmacies. And so there's only about 18 pharmacies in Washington that fill this prescription. The cost of the prescription is not covered by insurance. It's anywhere from $600 to $800. And we work with a foundation to cover that cost for folks who can't afford it, because we want to make sure that nobody is prohibited from accessing this prescription based on finances alone. Most of the visits with your providers during this process will be covered by insurance. However, the prescription is not. Some state insurances do cover the prescription, and we encourage anyone who has insurance to send their receipt to their insurance, hoping that with time they will recognize that this is a need for insurances to cover. And taking medical aid in dying medications does not affect your wills, contract. Your death certificate will still say the underlying cause of your disease. There are no life insurance policies that are affected by this choice. And people who take this medication fall asleep within 5 to 15 minutes. And the average time of death is about 1.2 hours to an hour and a half. Deaths can be very short. They can also be very long. Although there is, I think of this as parallel to birth. And so we know that birth is coming, just like we know this death is expected. And what we're doing is, like we are in inducing labor, we're inducing death. And we don't control the timing of it in the same way we don't control the timing of labor. And so there's definitely planning, and it will happen, and it is a guarantee, but the timing of that is still uncertain. And so we work with folks to figure out what support would look like in the case of a short death or a long death. And these look very different for different people. So sometimes they're really small, intimate gatherings. Sometimes they're huge parties with 150 people. There are sometimes amazing soundtracks, or just whatever that person wants, dances, spiritual practices, whatever that person wants, they get to help, dictate and find that place and day for them, which is a unique part of a medical aid in dying death. So something we did in 2020 is we passed a law called the Protecting Patient Care Act. And so where previously in Washington, folks who worked, so medical providers who worked in restrictive institutions could be prohibited from talking about end-of-life options with patients or clients. And this law basically prohibited that and said if you had a patient asking about Washington State's Death with Dignity Act, you had to give them relevant resources that were available in the community and how to access those resources, including referrals. So this has allowed a lot more of our providers and restrictive institutions to start giving ideally accurate information and referrals about end-of-life options. And I do think that this law has helped people working in restrictive institutions. It's offered them some safety to talk about this as an option because it is a legal healthcare option in Washington. And then this year, and I'm going to urge you all to please write your senator, urging them to support our current legislation that is happening in the House and State Senate right now. We are trying to change the medical aid in dying law in Washington that would shorten the waiting time down from 15 days to 7 days. It would also increase the amount of providers we have. So instead of just having MDs and DOs qualify folks, it would allow ANRPs and physician assistants to also be one of the two providers, which is a huge issue for access when we have a lot of folks in Washington who get all their primary care from a PA or an ARNP. And then it also modernizes prescription delivery. So right now, folks are really unable to e-prescribe these meds. There's only 14 or 17 pharmacies. And so this would allow pharmaceutical delivery of these meds for access issues and to increase accessibility. For example, in Eastern Washington, all of Eastern Washington, we have 2 pharmacies, one in Wenatchee and one in Spokane. So people are often driving 3 to 4 hours either way to pick up these medications. All right, so we're going to switch gears a little bit at the end here to talk about voluntarily stopping eating and drinking. So VSED is a voluntary choice to hasten death by removing nutrition and hydration, and it allows the body to die within 1 to 2 weeks. It really is the hydration removal that allows somebody to hasten death this way. It only takes 2 to 4 teaspoons of water a day to keep the kidneys functioning. So VSED really requires complete cessation of eating and drinking to be successful in a relatively rapid time frame. Often people who choose VSED, so this has been happening for years. There's nothing new about voluntarily stopping eating and drinking. We just have new language about it now. And more awareness about it as an option. You will talk about what you need in terms of support. Folks who choose VSED often have lost significant quality of life for themselves, but might not qualify for medical aid in dying. And so folks who choose VSED were like my dad, who had an early dementia diagnosis. He still had capacity to make this a voluntary choice, but because of his dementia, couldn't do medical aid in dying. Another example is somebody with Parkinson's or ALS who doesn't want to live to the end stages of the disease where they might qualify for medical aid in dying, and so they choose voluntarily stopping eating and drinking. We've also had people choose for just a wide range of reasons this is an option, and some of them are not terminal illnesses in the same way that they would qualify for medical aid in dying. And so that's why they end up choosing VSED. Other people choose this. And in fact, the Netherlands, people choose VSED at twice the rate of medical aid in dying because it is a more natural process. And for folks, sometimes the spirituality or their religious practice allows this passive hastened death to be more aligned with their values and choices. So with VSED, what is really key is that you have collaboration with a care team. So you are controlling the time and nature of your death. You have a chance to change your mind in the early stages of the disease, but it is really important that you have the right support and good collaboration. And so you want to be able to talk to your providers about this. You want to be able to get on hospice care within the first 24 to 48 hours of starting this as an option. And you want 24/7 caregiving during this process. And so that caregiving can look like family and friends. It could be hired folks. But this is not something you can successfully and comfortably do alone. You need a range of support to make this possible. I have seen people do this with one person around them or two people around them, and I have seen this be done with multiple people around them. But you need some form of support to make it through the process. So when we talk about dementia, when you're thinking about dementia and planning for end of life, you want to make sure you have that advanced directive and that healthcare agent. You want to make sure you have your dementia directive filled out. You want to make sure you have a pulse if that's something you think you're going to want as your disease. And then the place that voluntarily stopping eating and drinking is available for somebody with dementia is in the early stages of their disease. So when they are in their early to mild stages of dementia is when they still have the capacity so that the stopping eating and drinking is voluntary. Sometimes it's said with VSED that you're giving up some good days for bad weeks or bad years. And so people lose that window of opportunity when doing voluntarily stopping eating and drinking with dementia because you can get past the point of capacity to make this as a choice. If somebody doesn't want to VSED but still wants some options for their end of life care when they get to the moderate to moderately severe Alzheimer's stages, then you're going to have the My Instructions for Oral Feeding and Drinking or comfort feeding only measures. And so that is when you get to say, at a certain point of my disease, when I stop showing interest in food, I don't want to be given any more food or water. I just want to be kept comfortable and be allowed to die naturally that way. These are really important documents to have filled out if that's something you think you are interested in. They have yet to be contested in a court of law, and these documents are only as good as your healthcare agent who's enforcing them and potentially the care home that you have elected to go to. And so if you are like in the dementia directive, it asks questions about, do you have a sense of if you needed more advanced memory care, where you would want to go? And it encourages you to go tour some facilities. And I also encourage you that in those tours of those facilities, you have those conversations about, how, would you respect an comfort feeding only order from my healthcare agent as I got to certain phases of my disease? Because facilities have a lot of power and sway here. And it's important that you have that full information before committing to be in a facility if that's something that's going to be important to you at the end of your life. So this middle column is, you'll notice, the really most important people who will support you. You'll see on that list that those are your doctors, your physician assistants, your nurse practitioners. And this is why it really is important that you start having these conversations with your providers now and figuring out if and will they support you, if they can and will support you, and communicating with them what your end of life options are and what you think you value and what you might want as you approach that time in your life. Other resources are End of Life Washington, Friends and Family, healthcare providers, death doulas, spiritual and religious leaders. we're living in an age where more and more resources around death and dying are becoming available. And there's some great resources just in Washington in general is well resourced in comparison to other states across the nation. So I mentioned earlier that there are some other places that you can, consider for your end of life planning and maybe some other arrangements you might want to make. So final disposition arrangements are really important. If and when you get on hospice, they will help you with these. Some people choose to buy these ahead of time or think about these ahead of time. We now have, aquamation, green burials, recompose. We have tons of different options for final disposition now in Washington, and more businesses each day popping up to do final disposition arrangements. You might also have a designated agent about who you'd like to manage your estate after your last will and testament, after your assets and after you're gone. You might have a contact list of people you want to be reached out to. You might plan a celebration of life, do legacy work, have all of your accounts and passwords closed or managed. I helped somebody take their medical aid and dying medications a few years ago, and they literally sold their car. They had done they destroyed their computer. By the time they took those medical aid and dying medications on that day, there was truly nothing else left for anyone in their lives to take care of, because they were convinced that they wanted to do it all, which was great. Doesn't usually happen that way, but it can if that is something that's important to you. Worry Free Wednesdays is a resource that I mentioned. They're a group in Washington that will help you do workshops about doing your advanced planning and documents together in a group so that you are held accountable to do so. End of Life Washington has tons of resources also available on our website. So you can join End of Life Washington End of Life Ready presentation. You can always reach out on our phone number or email us. We're happy to support where we can and are a resource to all of you. And we want more people to know about their end of life options. So we really want you to help educate others by having these conversations with friends and coworkers or healthcare providers or folks in your community. End of Life Ready is a 40-minute presentation that allows, similar to what we've gone over today, that basically gets you set up for the basics of how to plan and prep for your end of life options. And then we also need more physicians. So if you talk to your physician and they're supportive, or you're a physician in the audience, or you know a physician that's retiring and that might be interested in doing this as a volunteer, we want to hear from you. Please connect them to End of Life Washington. We have medical directors and advisors that will reach out to physicians for education and coaching. And if we pass the new advocacy law that we're trying to pass, that would allow PAs and NPs to participate. So that would be even more providers that we could have in support for end of life options. So do join us as a physician if that's something, or encourage physicians in your life to join us, because that is a huge gap in care in Washington. We also always need more volunteers. So we provide training and support to volunteers throughout the state. We have different volunteer options. One is being an ambassador, and so doing education and presentations across the state. The other is being involved in direct services, so being that person who walks somebody through the medical aid and dying process and is there for the day of death. Those volunteers are also needed in Washington. And then finally, we're also 100% supported by donor dollars, and there's never a fee for all our services. We do everything free of charge. And so if you're in a place or get in a place where you can contribute to End of Life Washington, we're only able to do this work because of the donors that support us in this state. We also really encourage you to join us and sign up for e-news. So we send out every 2 weeks update on what's going on in end-of-life options and what we're up to. Right now, most of those are advocacy asks. So if you want to be prompted to reach out to your senators or representatives, if you sign up for our e-news, you get to stay updated on what's going on in our state around end-of-life options. All right, so I'm going to stop there and we're going to take our break and then we're going to come back for some questions.
So again, this will just be a very brief break while they switch over the setting here. If anyone needs it, the restrooms, you go straight to the back, hang a left, and then another left, and we'll see you shortly. Thanks.
Okay, we just got the signal from Tim that we can start. So before I start, I want to give a special shout out to Tim, who's hiding up there. He's our audiovisual guy. He was notified at 10 o'clock this morning about the need to have to do Zoom, and he had to race home and get a 200-foot extension. He pulled it off beautifully. So welcome. I'm glad to see you all here. Thanks to the League members who organized this wonderful, unique forum. And as they said, the League doesn't take positions on candidates, but we do take positions on issues. So this is an issue that the League has been involved in. So some of you have your programs. So I just wanted to clarify for you that on our program, you have Cassandra that you heard from, and she'll be down here on the computer. We have Dr. Paul Cunningham, and in the middle is Sandy Ulf, and then Dr. Jones. When we have Phyllis, she was unable to come because of family health issues. So we're going to start. The process will be that we'll have a League member holding a mic over at the end of this aisle and at this aisle. So if you want to come up and ask your question, we welcome you. Some of you don't like to get up in public and talk. So if that's the case, write your questions out, hold your card up, and someone will pick it up and deliver it to Mary. So the questions will go one question from live mics, and the next question will be a written question. So we'll give equal attention to both. So I think we're ready to start, and what we'll do is have each of our panelists, starting with Dr. Jones on my far left. Cassandra, we already had your introduction, right? It was a great presentation. Thanks for doing that. So we'll have Dr. Josh Jones to introduce himself, and then Sandy, and then Dr. Paul Cunningham. They'll give a little of their background and why this is an issue that's important for them, and then we'll go into the questions. Okay, Dr. Jones, you're on.
Well, hello, everybody, and thanks for being here, and thank you, Cassa, for that wonderful presentation in the hour before. So my name is Josh Jones. I'm a psychiatrist, and I'm also the Chief Physician Officer for Olympic Medical Physicians in Olympic Medical Center. So I oversee all of our employed physicians and all of our outpatient clinic endeavors at Olympic Medical Center. And I'm really happy to say that Olympic Medical Center complies with the law and supports our physicians who are willing to provide services under the Death with Dignity Act. But also that we integrate palliative care and end-of-life care into pretty much all aspects of what we do in the inpatient and the outpatient setting. It's part and parcel in the inpatient units, in primary care, at the cancer center, and a really important part of the healthcare continuum. So happy to be here, and thanks for having me.
Good. Okay, and Sandy Ulf is next.
Hi, can you hear me? I'm Sandy Ulf. I'm an RN. I have been in healthcare. It'll be 50 years in December. I was 3. So I recently retired last May from actually working kind of with the public. I have a small job, which is actually really an incredibly important job. I am working for the state, and I teach providers and other clinicians how to have serious illness conversations with patients. Many of our providers went to school where they really didn't teach that knowledge, teach that skill. So we found that it's been incredibly important and helpful, and I really enjoy that work. I was the advanced care planning coordinator for the last 5 years, which meant I was the person that some of you maybe came to advanced care planning workshops where we filled out your documents. So they have not been able to fill that position at OMC, but I'm hopeful eventually they will. I was a hospice nurse, and I'm an end-of-life doula. This is the first time I've ever been in a presentation where they actually talked about end-of-life doulas. The concept has been around for a long, long time. Has anybody ever heard of an end-of-life doula? Oh my gosh, wow, I don't need to tell you then. I mean, it's all about helping people with their paperwork to helping plan a vigil. So it's really about organization and planning, working with people that are in the end of life and also the people who care about them. So that is something I really enjoy.
Thank you, Sandy. And Dr. Cunningham.
Good afternoon, everyone. Paul Cunningham, and thanks to the League of Women Voters for including me in this panel. As it pertains to today's discussion, I am a physician at Jamestown Family Health Clinic. I've been here on the North Olympic Peninsula for going on 20 years now, taking care of patients. I maintain board certification in family medicine, geriatrics, and hospice and palliative care. So subsequently, I've been involved in end-of-life care for many hundreds, if not over 1,000 patients in the last 20 years. Depending on the nature of the questions today, I may answer as an individual physician or I may answer as the Chief Medical Officer at Jamestown Family Health Clinic. And if I didn't say that earlier, I've been at Jamestown since 2003, and I've been the Chief Medical Officer since 2019. So it's good to be here, and I look forward to the questions.
Thank you. So now we'll start with the questions. I say if you want to come down to the end of the aisle of here or there, there'll be someone with a microphone, and you could ask your question. And so Mary already has one in writing, so we'll start with a written question and hope that some of you will make your way on down to the mic.
Okay. Many hospitals in Washington are controlled by the Catholic Church. Are they honoring death with dignity and end-of-life wishes, as far as any of you know?
Okay, so what we'll do with each question is give each of our panelists a chance to answer, and we'll rotate who answers first. So for the first question, Dr. Jones, you're up first.
I'm actually gonna pass. I think we should pass that one on to Cassa. Actually, I think she's probably gonna know way more about the statewide view than I do, for sure. So I will cede my time.
All right, and so Sandy, okay, and Paul?
I agree.
All right, so Cassandra, you're on.
Come on, y'all. So our hospitals that are Catholic in Washington cannot participate in medical aid in dying. There are gradients of how this looks depending on the hospital in Washington. So we have some hospitals or systems that have gone as far as in their contracts of prohibiting their physicians to even participate in medical aid in dying on their own time. Something we're trying to change this year in the law is to basically, there's a new line in it that says you can't prohibit in a contract from somebody participating on their own time in medical aid in dying. This has happened with some of our Virginia Mason physicians, for example, when they merged with Franciscan 3 years ago now. Some of them do this work as volunteers. They literally take these calls off Virginia Mason property at their homes, in their cars, to make sure that patients still have an access to this. So some of it, by contract, people can't even participate on their own time. It has changed slightly in the last 2 years that I am seeing a little bit better around the education and referrals, just because of the Protecting Patient Care Act that allowed folks within restrictive institutions to talk about this more. We're getting more and more folks who are getting at least a little bit of information about medical aid in dying and being referred to End of Life Washington, but still those institutions are not participating. Same thing with Catholic hospices. Their social workers and nurses might be able to talk about medical aid in dying, but can't aid or assist in any way and can't be there on the day of ingestion. So they have like a leave the room policy. So the short answer is no, these Catholic hospitals are not participating in medical aid in dying. They often are not offering the full range of end of life options as well. They will not bring up medical aid in dying as an option to their patients. They will wait for their patients to bring it up to them. So the onus is on the patient to know that this is an option in Washington, and bring it up to their provider. And hopefully that provider will then refer them to somebody who can and will support, which right now ends up being End of Life Washington in finding providers.
Thank you, Cassandra. Does anyone want to come up to the mic?
Actually, Norma,
Yes.
I'm going to, now if you don't mind, I'd like to piggyback off
Oh,
that.
all
And then
right.
just contrast that with the situation that we have here in Clallam
But
County.
Josh, push your mic a little away from you're too close to it. Better. All right, thanks.
To contrast that with our situation here in the eastern part of Clallam County, Olympic Medical Center is not under that kind of situation. And even though we're affiliated with a Swedish Medical Center, which many of you know is now merged with Providence, they don't write our policies or tell us how to do things like this. That's controlled by our locally elected board of 7 officials who direct the strategic plan of the hospital. And so we're not under that, and we're proud to support our physicians who choose to participate in all end of life care, but also medical aid in dying, and have provided those physicians who choose to do that with tools to navigate the pretty difficult and convoluted documentation that goes along with that. And so we have our compliance folks who have a nice tool to help them do that, and we double check that. So we're not in that situation here in Clallam County.
Okay. Well, I want to make sure that Paul and Sandy can recoup your time. Do you want to comment on this, Sandy?
I just want to make one comment, just in case you don't know this, is the medical aid in dying is typically not done in an institution. It's done in your home. And so just so you understand that, it doesn't matter what your affiliation is. OMC has that policy. We don't have that process within the hospital itself. And that's true of almost all institutions. I think Whidbey Island did for a while, and I'm not sure if they still do, but just so you know that.
Okay, Paul?
Yeah, thank you, Sandy. You made one of my 2 points, which is this rarely to never happens in the hospital setting now, but the spirit of that question, I think, extends to the fact that faith-based, be it Providence or other institutions, do run outpatient primary care clinics, so you might run into it there. I also, in case it's not clear, we've alluded to it, kind of said it, but secular or faith-based organizations, this is an individual physician decision. So whether I work for Providence or I work for Jamestown or Olympic Medical Center or North Olympic Healthcare Network for that matter, it comes down to individual decisions. So in the same way that, say, a Providence may limit participation by their physicians, Jamestown or OMC may not compel physicians to participate. So this ultimately is an opt-in, opt-out on an individual physician level.
Thank you.
Cassa, did I get that right?
Yeah, I would just say secular institutions, I love when physicians who opt out say, well, let me talk to my colleagues in the office and see if they're willing to support you in caring for this. And we have a real need of places to take these meds. Sandy, you're totally right. It doesn't happen in hospitals. We in Washington have used other volunteer homes because not everybody has a home to go to. We've had to use cars, hotels, but there's now an organization called A Place to Die where people can volunteer their ADU units or guest rooms for people to come and take these meds because not everybody has a space to take medications. Often in some nursing or retirement communities or independent living facilities, depending on their policies, medical aid and dying medications can sometimes be taken there, but they are not taken in hospitals or institutions.
Thank
Yeah,
you.
well said.
That's an interesting concept we have to all think about. Not everybody has a home to die in. So now, is there someone who wants to ask a question using the mic? Be my guest.
I have one. For Dr. Jones, I know that the hospital is about to open a new hospice, and I'm wondering if, even though, I guess in 2008 or 9, the League of Women Voters Healthcare Committee testified to the board asking the hospital to permit medical aid in dying on the site. It decided not to. But now that the patients who are eligible for medical aid in dying will be in their own homes on hospice, will physicians be permitted to support patients in that? And does the insurance that they require from the medical center also support that?
Thank you. Okay, since it was directed to Dr. Jones, he'll go ahead and answer first, but I'm going to let everybody have a chance to weigh in on that.
Yeah,
Okay.
great question. And let me be very clear that the 2008 policy that Olympic Medical Center created was just to push or to move the site of taking the medications not in the inpatient unit, but in the outpatient unit, and has never prohibited physicians from participating in medical aid and dying conversations with their patients. So that wouldn't be a change that's happening now. And we're happy that those physicians who choose to do that, and again, as Dr. Cunningham so rightfully said, it is just those physicians who choose to do it. I have no ability to compel anybody to do it if they don't want to. Those conversations are happening already.
Okay.
And sorry, the insurance. Now, can you clarify your question?
So the question, I believe, is does the insurance cover it?
Yes, one of the big issues statewide about access is that physicians who are prohibited from doing this in facilities by their employers or in their own hospices where they work by their employers, they hesitate to do that because their malpractice insurance is provided by the entity that employs them. So they have no malpractice insurance, and given that they're dealing with the death of a patient, they feel vulnerable and therefore are less willing to volunteer. And it's especially harder for retired physicians who don't have malpractice insurance. So it's a dampener generally on the availability of providers to offer this.
Okay, so clarifying, you're asking about malpractice issues insurance, not patients.
More specifically to OMC, and whether its malpractice will cover the physicians for patients that are in hospice.
Thank you.
Yeah, and the answer to that is yes. For those physicians who are employed by Olympic Medical Physicians, our malpractice insurance does cover them, and they're able to provide those. Now, for retired physicians or anybody else in the community who wants to do it, that obviously would not cover them. They'd have to secure their own insurance. But you did also touch on another point that I wanted to clarify, is that there is a little bit of a discrepancy about what health insurance will cover. Now, Cassa very, very rightly said that it does not cover the medications, but also no federal dollars can be used, and this is by law, no federal dollars can be used in the provision of services leading to medical aid in dying. And we've gotten many different interpretations on that, and that seems to suggest, and we kind of just, right off at this point, those folks who are covered by Medicare or Medicaid for those services. So it's, I just want to be very clear, especially when we start talking about, well, why don't physicians do this more? This is a very complicated process for which governmental payers aren't willing to pay for it. And Olympic Medical Center, for instance, has an 83% governmental payer mix. So we're doing it anyways, but it's against the law to collect money for it, which we do not.
Okay, thank you. Okay, so Sandy or Paul, you want to weigh in on this discussion?
Not right now, thanks.
Okay, all right. Cassandra?
Yeah, I just wanted to say that for our retired physicians who do want to participate in medical aid and dying, we help secure them malpractice insurance through the Volunteer and Retired Physician Program. So they are covered by malpractice, and that's something End of Life Washington is a designated site for that. And so we cover them through that collaboration. And I would love to connect you with some other hospices and hospitals that are charging for these services. The Federal Funding Act does prohibit charging any Medicare or Medicaid dollars, and there are hospices and institutions that have figured out their coding and how to designate what services they're charging for and what they're not. But it is definitely still a gray area in all of the states with medical aid and dying laws.
Thank you. Okay, now we're going to take a written question.
I have two here. One is very, very quick, I think. Simply, who is the written request submitted to during the death with dignity process?
So read that again.
Request,
Okay, go ahead, Cassandra.
yeah, so the written request is a document that happens after the patient has seen both the attending and the consulting physician. It is a document that the patient signs, basically saying, I am doing this of my own free will. And then it is witnessed by two people, one of which can be a blood relative, one of which who cannot. And once that document is witnessed, it goes back to the attending physician or the prescribing physician, the same person, different, we call them different things. And that prescribing physician is responsible for collecting all of the paperwork through the process. And they are responsible for mailing it all to the Department of Health. And yes, I said mailing. We still live in the law that was passed in 2008, where physicians are literally pen and papering 9 to 15 pages of documents and then having to snail mail them to Olympia, where they get compiled in a big box till the end of the year when somebody has time to go through them. And so part of the law we want to change is to allow electronic submission of these documents.
Thank you. And so is there some local comments for the panelists here on how it's handled here locally?
No,
she
I mean,
nailed it.
let's go on, Josh.
No, good. Go, Paul.
It's a fairly straightforward process and yet a somewhat unwieldy process. And I'll just give you a little flavor. In the same way that an individual physician may choose to participate or not, an individual pharmacist may choose to participate or not. We go down a long rabbit hole on this discussion, but if, let's say, for example, I have a physician at my clinic or Dr. Jones has a physician at his clinic and they want to participate, well, what about others in that chain? The medical assistant rooming the patient, the nurse advising the patient. You know, we could spend 2 hours on this discussion, and Cassa could probably spend 4 hours on this discussion because she's probably seen countless scenarios. But the fact of the matter is, it's not just a physician participating in this. So entities need to be cognizant of the law, which allows folks to opt out. And it is, in fact, as I recall, when this law was coming up, and I used to be a part of some end-of-life groups long before this law existed, when there was some advocacy around it, a key component to this law is the opt-in, opt-out nature of the law, because I would share my personal bias, which is I don't think the law probably would have passed if it did not have that component to it, but I could be wrong.
Okay, so Sandy, you're dealing with patients. Is this an issue?
Not an issue. So the biggest challenge is it's difficult.
Yeah.
And so you have to be thoughtful about this And if you think you want to choose this option, start the conversation. Because you never have to take the meds. So if you think you might want this option, start that conversation early with your provider. Make sure you have a provider, because it takes a while.
Yeah.
Yeah.
Okay.
Yeah, I think that's a really good point. And I've talked with some folks who want to avail themselves of medical aid in dying, and they say, well, this should just be a routine part of healthcare. And that is certainly a stance I think that can be taken and defended. However, it is certainly not a routine part of healthcare with all the bureaucratic red tape that goes along with it. These are not things that we have to do if we just want to treat somebody with diabetes or another health condition. So as difficult it is to find folks who are willing to do it, or physicians who are willing to do it, there are reasons. It's challenging. And by the way, the auditors do not have any senses of humor on these matters.
All right.
Well said.
So, okay,
Norma,
I'm going to make sure we try and limit the discussion on each question to allow as many questions as possible, because we do have to leave here at 3, because that's how long they rented the facility. So go ahead if you want to make a comment.
No, I'll wait, because it'll probably come up in one of the questions.
Okay, I see someone has a microphone over here. It's time for an oral question.
Hi.
Hi, Mary.
Hi. So I'm a medical social worker, and I often work with people who are end of life or, terminal or serious illness.
Okay.
And
Okay, I'm going to ask one thing, is that if you'll just ask your question in order to expedite, so we
Sure,
can get as many
sure.
questions as possible.
So I wonder, I am often in a situation, not often, at times in a situation where it seems to me someone that I'm working with doesn't have this information. And I generally operate on the assumption that I can't suggest. This is an ethical question. So I'm just wondering if that's true, that I can't suggest, like just even contacting End of Life Washington, if I think that they might be interested. I don't know.
Okay, Cassandra's ready to address that one. Go ahead.
I mean, I would say check with the policies for where you work. I work with physicians who are hospitalists, and they believe that this is just one of the many options that they present to their patients as part of routine healthcare. I know that a lot of hospices and medical centers have a policy around, like, if the person is suggesting that they might be interested in this as an option, that is where you would say. So for example, we treat our pets so much better than humans. I don't want to do this anymore. I wish there was an option to die sooner. Any of that language that is suggesting to you that they might want this as an option, that's where social workers and nurses are trained to say, you do have some legal options in Washington. Would you like to hear more about them? Especially with the Patient Protection Act, anyone who is seeking end-of-life options is legally required to be given accurate resources and information, including referrals. So your employer cannot put your job in any threat by you talking about Death with Dignity Act, talking about end-of-life options, or making referrals to End of Life Washington. I also don't think that suggesting this to every patient you have makes sense. And so that is why listening to that person's language and how they're talking about their end of life is where you can have that doorway in of, you actually do have some choices. Do you want to talk about those? Tends to be a great kind of segue.
Okay, and Paul, you have a comment?
Great question, and I'm going to spin off a little bit, and I'm guessing if Sandy went before me, she'd say about what I'm going to share with you right now, which I know we're here to talk about medical aid in dying. Sorry, I still think of it as Washington Death with Dignity Act, Cassa. As a physician who often wears a palliative care hat, and I talk to colleagues, physicians or otherwise, I talk to any member of the healthcare team, often multidisciplinary. I've worked with hospices, nursing homes, and there's often a sense of trepidation, let's say on a provider. Let's say you're a family medicine provider anywhere in this state, and you see on your schedule, Mr. Smith come in and talk about physician-assisted suicide. Let's just charge it right up front. That can cause anxiety and trepidation regardless of where you are as an individual physician, nurse practitioner, physician assistant, social worker. And to me, I just see this as a great opportunity. And this is what I tell some of my junior colleagues. I say, someone's coming in to talk to you. First of all, isn't it awesome that they trust you enough to come to you and reveal themselves? I mean, this is one of the most vulnerable moments in their life where they're going to talk to you about their death and how it can go. And so where it's true that a medical assistance in dying may be part of the conversation, take it at a larger view, sit down with the individual like we would in any situation, say, Mr. Smith, I understand you're here for this. Tell me about it. Lots of open-ended questions. What are you hoping for? What are your goals? What are your wishes? What are your fears? Okay. And sometimes they will be very clear. I came to you, Dr. Cunningham, because I want to get a prescription to hasten my death. And other times they want to be reassured that regardless of where they are in their journey in life, that you're going to be there for them. And I don't know if Cassa had a slide earlier about the top reasons. You know, we have so much data on this now, why people choose it. I'll rattle them off, but they include concerns about suffering, physical and emotional. They include concerns about being a burden. They include concerns about financial concerns. Importantly, they often cite wanting to have control. You want to have control over the timing and the setting and the nature of your death. So getting at that is imperative before we talk about a prescription for phenobarbital or Seconal, whatever is out there these days. So it's an opportunity to engage with a patient and see where they're coming from. The data has shifted, I think. When I looked at the data from Oregon almost 20 years ago, the majority of people who got prescriptions did not exercise it. And now, looking at the last data in Washington, I think Cassa mentioned this, about 3/4 of the 500 or 400 some odd individuals who got a prescription in Washington State exercise that. So Cassa could probably speak to that, but whether people are becoming more savvy, whether people who want it are really just going in and advocating for themselves, I don't know. But this is an evolving topic in the public. But again, it's an opportunity for you and your healthcare provider to talk about what's important to you.
Thank you. So Sandy, since you're dealing with your patients, do you have any comments?
So I just want to say that Paul is absolutely right. Sometimes people haven't had the opportunity to really talk about their situation and really talk through what their needs are and how to keep them comfortable, how to help them with their fears and anxieties. So it helps you open a conversation. It doesn't mean we should shut people down about that option, but sometimes you can do a lot of other things and still have this choice. But sometimes there's so many things we need to do now and not wait for all that time to make you breathe better, have less pain, do lots of things. So it is a great conversation opener.
Okay, so are you ready to move to the next question, or did you want to make a comment? Okay, so I think we're on to a written question.
Yes, here's a good one. Confusion that I think many of us have. Death with dignity or medical assistant aid in dying has a criteria of within 6 months of death. But what about hospice care? The person who wrote this note said they had attended a session done by Assured Hospice that said that hospice can provide services to patients with more than 6 months to live. So what is the timing to enter hospice?
Okay, so since we have a hospice nurse here, we'll start with Sandy.
Okay.
Former hospice nurse.
I don't think you ever are never a hospice nurse when you've been one. So the question to ask should always be, would you be surprised if this person would die in the next 6 months? And I can guarantee you these two gentlemen and all the people they work with use that language, because there is absolutely no disease that has a 6 month deadline starting today. So when they said that about hospice is, would you be surprised? So, and you have a disease or disorder that kind of fits that. I mean, as a hospice nurse, I had a patient that was on hospice for 3 years. So, you know, as long as that patient continues to qualify and continues to have needs, then it can last longer. Most people join hospice way too late in their disease and don't really benefit nearly as much as they could. They wait until their condition is so desperate that they're on hospice for 2 days, 5 days. And we really want to think about hospice much earlier in our disease trajectory because it helps you live better. People have much better quality of life when they're on hospice. So kind of think about that, and think about that for people that you care about.
Okay, and Dr. Jones, do you have any comment?
Yeah, thanks for that, Sandy. Both of my parents died in hospice, and they actually had the wonderful hospice facility, standalone facility down in Longview in Cowlitz County when I was younger, and so I'm a big hospice devotee. But I also want to point out that, and Cass is probably much more of an expert on this than I am, even the law for the Death with Dignity Act, the 6 month is a guideline. It has very permissive and appropriate wiggle language in the law that says you need to be projected to expire within 6 months, and I believe it's something like within a reasonable degree of medical certainty or something like that. So and this is something that I counsel some of our junior physicians on is, if you've done this in good faith, if you've done this within the realms of medical science, people aren't going to come at you for that if it's 6 months and 1 day or something like that. Cassa, is that consistent with your experience?
So Cassandra, you want to comment on this question?
Yeah, I just want to reiterate that hospice, we want all of our clients to be on hospice because they are such a wonderful resource and support for folks. And in fact, some of our volunteer providers won't work with a patient unless they're on hospice. We have had patients qualify for medical aid in dying that have lived for years and years because we are not good at giving a 6 month prognosis. In fact, the research shows that the physician that has seen that person for years is actually worse at it than their colleague who just looks over the chart and is able to make that patient way quicker, because we are human and we get emotionally involved. I think what is really interesting is that, excuse me, New Mexico is the most recent state to pass medical aid in dying legislation, and they wrote theirs completely differently. And that if somebody is already on hospice, they only need one other provider to sign off on medical aid in dying. It's the only state in the nation that has done this, that has really linked hospice with medical aid in dying. But even folks on hospice right now sometimes don't qualify for medical aid in dying, which is kind of wild to think about, but it does happen where we'll have a case where the physicians will look at this and say, I think this person was put on hospice for the extra resources that they garner, but I don't actually think that they're terminally ill at this moment and I can't qualify them. It's rare, but it does happen.
Okay, so Paul, you have a comment on this question?
Yeah, briefly. I'm super big fan of hospice, so yay, go hospice. And anyone in this audience who participates in hospice care, thank you for doing that, and please continue to do so. A couple things. As far as 6 month prognosis, as Cassa pointed out, yeah, when we know you, we're people pleasers, or we like you. We want you to live forever, not just 6 months. So we do overestimate it. So there's a couple lessons you can take that. Don't go see the doc who you like and likes you. Go see someone else. But believe it or not, the government has figured out a safeguard, which is you don't just come to me and ask me how long you had to live. The unbiased hospice medical director who probably has never met you and is just looking at your data on a piece of paper has to weigh in. So there's a little checks and balances there. The other comment I would just say is, last time I looked, this is probably a few years old, but let's see, the average length of stay on this is weird data, stick with me for a second. The average length of stay on hospice is about 62 days. Well, that's not too bad. And yet over 50% of people go on hospice live less than 20 days. Right? So I don't know how to interpret that. I could, but that's another discussion. The point is we're pretty bad at predicting life expectancy. And if anything, we way overestimate, oh, you're not ready for hospice yet. And 50% of the people die within 20 days when they get on hospice. So it's a weird little dynamic.
Okay, I'm going to do a time check here and find out how many written questions do we have?
I have about 4 more.
And how many do you have? Okay, so we have 10 questions and we have 20 minutes. So we're going to go ahead and ask the questions, and I'll ask people to kind of give short, concise answers, even though this is a complex topic.
I have
Lightning round.
I have
Okay.
a really quick one that can be answered just by one person, so,
Okay.
a couple of them. So first I'm going to go to Cassandra. How can they get to your PowerPoint?
How do you get to your PowerPoint, Cassandra? That's the question.
I believe this will all be recorded, and you all have it, so you're welcome to share it.
Okay, it'll be posted on the League of Women Voters website.
And that's the
Okay.
second one, is this being recorded?
Yes.
And can they get it on the website? League of
Yes.
Women Voters website? Okay.
Yes.
And give it a couple days, guys. There'll be a
Okay.
tab on that. And then this is the other question this person had. With a POLST, a pulse and a DNR, in an assisted living facility, first of all, will they honor it? And will it also be honored by EMTs that come in? So EMTs and staff members at a assisted living facility.
I want to answer that.
Yeah, okay. So Sandy wants to answer that.
So by law, everyone needs to honor a pulse form, but many facilities have their own policies and they don't. So what's, again, really important is that if you have a pulse form, that you know what your facility is going to honor or not. So we have a nursing home here in Port Angeles and one in Sequim that do not honor pulse forms. They have a DNR order, but they don't honor a pulse form. So it's anyway.
So it's something you need to be aware of.
Something you need, it's just like anything else. Understand what the policies are of the facility that you're going to be in, especially dementia, and what the rules are and what you're going to want. And is that facility going to honor what you want? It's just really, really important.
Do we have any additional comments before we move on to?
I would just add that in general, facilities, thank you, Sandy, facilities will generally honor a pulse, but keep in mind that some of these facilities are owned by out-of-state entities, so they have their corporate policies and procedures, right? So it's not as if they're going to disregard a pulse, but they also want generally the family or surrogate decision maker to take the extra step of documenting on their own form. Is that fair, Sandy? Yeah, it's a big conversation, but
Okay.
Big conversation.
All right, so Mary.
I got a couple quick ones, maybe. I think you, Cass, addressed this. Is stopping eating and drinking considered by anyone suicide?
Okay, you hear the question, Cassandra?
Yeah.
Okay.
No, it is. I mean, yes, I am sure there are people out there who think of this as suicide. Based on the legal and ethical conversations that are happening in our nation and the world, this is not suicide. The underlying cause of death listed on the death certificate is usually the underlying disease, and then dehydration is often listed as a primary cause of death. There's nothing on a death certificate that says suicide. This is a rational and medically supported choice in voluntarily stopping eating and drinking.
Okay, anybody here at the table would like to make a comment? Okay, and another, we have a verbal question. Okay.
Yeah, sorry.
Go for it.
Yeah, probably because of burdens and being a society. I was wondering if, for the death with dignity form, you can only fill it out once you're terminal. I was wondering if it was possible that you could, do like a verbal, like video or something like that, saying that this is what I want, and I might not be at that position to be able to do it at that time. And possibly because the law may change before that time comes along. So, say that, I have Alzheimer's and the law changes, and that's what I would have wanted. And I would like to be able to tell them now, that what I want in the future.
Good idea.
Okay. So, Well, Sandy, go ahead and continue your answer.
I mean, I'm just saying it's a good idea. I mean, and if the law changes, because I don't know about you guys, but the longest time I've known anybody with dementia was about 12 years. So that's a lot of change from making your own decisions to not making your own decisions for a really long time.
Yeah, what I would add to that is I love the idea of doing a video for all the reasons we've talked about today, but it does not apply to this law. So no, the answer to your question, if I understand it, is can you do a video and 2 years from now you're demented and you meet the criteria and thus a physician can fill out the paperwork based on that? The answer is no. I'm guessing Cassa's shaking her head in agreement with me on that. But no, seriously, I do love the idea of a video because all these pieces of paper we're talking about, big fan of Advanced Directive, big fan of Pulse, but as Cassa pointed out, they're only as useful as the conversations behind them. Because at the end of the day, if you are laying in a hospital bed and are alert, awake, and can communicate with your provider, we're going to ask you, what do you want us to do given these circumstances? These pieces of paper, and particularly a delegate, a surrogate decision maker, are when you cannot do that, and then we'll turn to them. And in fact, I will just say, just to amp you guys up a little bit, regardless of what your paper says, if your delegate says something else, so choose wisely and let them know, because the other part of this is when I sit down with a patient and their delegate, which is often a spouse, sometimes an adult child, often a neighbor, I look at the delegate and I say, just so you're clear, I am not going to ask you what you want me to do for them. I'm going to ask you, if they could talk to me right now, what would they tell me? So think about that one, because you are not going to be burdened with making a decision. You are being asked to take on the responsibility of speaking on their behalf based on what you know their values are and what they have shared with you. And that's a totally different. And side note, I've sat in with couples crying, I mean, really high energy visits where they disagree. The patient with a serious medical condition says, I do not want to be resuscitated under these circumstances. And the loved one is like, I cannot support that. This is real life. And so your spouse may or may not be the best person for you to appoint, but I'll leave it at that. And we can sidebar later if you want.
Yeah. Okay. All right. Any other comments?
I'm okay.
Okay. Written question from this side of the room.
Okay, so this is for the volunteer stop eating and drinking. What usually happens during that 1 to 2 week period of time? So what is it? I mean, I know they voluntarily stop, but what is the physical, what happens?
Okay, so the question is what happens to the patient during the couple of weeks, the time between they stop eating and drinking and they actually expire. So who wants to start with that one?
I'll start.
Okay,
It
Sandy.
totally depends on the patient. So if you have a patient who is extremely debilitated, bedbound, has lost 50 pounds, hasn't really been eating well for weeks, that person will take a lot less time and they will get quieter. They will eventually become basically comatose and they will eventually die, which happens to most people anyway. But a person who's still fairly healthy, then they're still fairly healthy for a while before their body, it slows down. You know, they maybe get weaker. There's things that happen. So it's so dependent on the situation of that patient. Yeah. And it can be, I've seen a patient debilitated in a bed with no food or fluid for 3 weeks. So, yeah, so individual.
Cassandra, you want to comment on that?
I mean, yes, it completely depends to the person, and there is really no guarantees around the timing. Typically, there's a lot of planning and prep that goes into a VSED process. Often people will do some kind of fast or cleanse before starting, so cut down on caloric intake for a week before they transition to no food or water or do a colonic. And then I usually think of VSED in kind of 3 loose phases that can look different for everybody, but the first phase, if somebody is often alert and oriented, pretty, being treated with some anxiety meds. Then a second phase is really like this transition phase is often the most difficult part, where there's more intense need for symptom management, really good mouth and oral care. The person is then in that middle phase losing capacity and slowing down more and more to becoming bedbound if they weren't already. And then in that final phase is when somebody is pretty primarily sleeping or comatose and really in that actively dying phase. And it often kind of follows that trajectory, and it looks different for everyone at the same time. There is a great resource out of Bellingham called VSED Resources Northwest. I highly recommend that if you're interested in VSED, you can give them a look. There's a recent handbook that came out called the VSED Handbook that is written by a local Pacific Northwesterner that outlines the VSED process and the planning and prep for it. It's a great place for more information.
Thank you. Okay, let's see. You have a question?
Yeah, I have a couple here. Are there local physicians who do support death with dignity? Dr. Jones, you said there were. How would we find a physician if our physician does not support death with dignity participation? What do we do next?
I don't have a very good answer for you. The physicians at Olympic Medical Physicians who participate in Death with Dignity do it for their patients, especially those primary care providers who have, those folks who are primary care providers. None of them that I know of are interested in being kind of a physician who attracts folks looking for this outside their already natural history panel of patients. So I don't have a good answer for you about that.
Okay. And so, Paul?
Yeah,
Sandy?
Excellent question. What I would add to that is simply check in with your primary care clinic, right? And just ask them, I'm looking for this, and does anyone participate? And you'll get your answer. And then Washington End of Life is an excellent resource for connecting with folks.
Okay.
Yeah, I'm gonna say, ask your provider, and if they don't participate, ask if they can refer you to a colleague that does or will. And End of Life Washington will never leave you without a provider. So if you do become eligible for the law and don't have supportive providers, we will help find and support you in that way. We have a provider shortage though, so it's not a day or two turnaround. Sometimes we're waiting on finding providers and a person dies within that time period because their providers weren't supportive and they got to us too late, and we found providers in 4 days, and that wasn't long enough. So it's really imperfect and frustrating in Washington at times.
Okay, so I think we'll take one more question from here and one more from there, and then that will wrap us up. And I apologize ahead of time if any of you submitted questions and didn't get them answered. Perhaps you can corner some of our speakers on the way out.
Okay, so this question comes from somebody who says they were recently told by an RN that they were in for a day surgery. So I assume it's not a serious illness here. So a day surgery, that DNR does not apply to this surgery. When I asked my surgeon, their answer was, yes, there is a DNR in surgery. So what's the real story? I have a pulsed and a DNR on my medical ID bracelet.
Okay, so your question is specifically?
Yeah, does a pulsed and a DNR apply when you're going in for a day surgery?
Okay, so that sounds like a Dr. Cunningham or
Well,
Dr.
yeah,
Jones
Josh, I mean,
answer.
I'll take a stab at it.
Yeah.
So the short answer is, generally speaking, your DNR is paused when you're going for surgery. And the reason is a practical one. Let's say, let's just create a example. Your DNR because you have metastatic cancer of some sort, but you're going to live another 1.5 years based on current therapy, but you've got a DNR saying, if I have a natural death, please let me go. But now you're going to go in because maybe you broke your leg and they need to put a pin in it. Neither the orthopedic surgeon nor the anesthesiologist attending to you want you to die on the operating table while you're having that surgery unrelated to your other end-of-life issue. Josh, did you want to add to that?
No, that's exactly right. And especially if it's an elective procedure that maybe perhaps a day surgery might be like this, then you're going in for something. And if you were to need resuscitation at that point, then you've had some reaction probably to an anesthetic or something that's going on in the procedure that we're going to try to resuscitate you from.
I want to disagree with these gentlemen. And part of this is personal experience, but if you truly,
Yes.
you have metastatic cancer, you broke your leg, if you don't get your leg fixed, you're not going to be able to be mobile, and you're mobile. You can have a conversation with your anesthesiologist and your provider to say, I understand you're going to put me to sleep, therefore you need to breathe for me. But if my heart stops, I choose for you not to restart it, and you have that right. So from a patient advocacy, I went through this with my husband when he was dying. So it will stop the medical team for a second, but you have the right to say, I get you're going to breathe for me, but if my heart stops, I choose for you not to do anything. So, sorry guys, but
No, I
No,
don't.
we're all three of us, Sandy, are right at the same time.
Yeah.
Because if it is that nuanced,
Yeah.
you absolutely should
Yeah.
be having that kind of conversations. If you're, me, for instance, and I have a DNR, and I'm going in to get a carpal tunnel surgery, if we don't have that specific conversation, they're going to suspend the DNR if you go into cardiac arrest and try to bring you back. But you, as Sandy points out, you absolutely have the right to make it more nuanced and say, hey, this is the situation I have. I want to meet with you're going to meet with your surgeon beforehand. You can request to meet with the anesthesiologist beforehand, especially if it is of such a morbid condition like that, and make it so it fits your preference.
Okay. So I see now that our time is up. I want to ask, do you want us to draw this to a conclusion, or do you want to extend it 5 or 10 minutes? It's up to. Pardon?
She says we have time.
So we'll extend for 5 or 10 minutes? Is that what you're telling me? Okay, we'll just take it. I mean, they do have to get up and get out of here because of their time constraints, but there are more questions, so we'll go ahead and extend this for like 5 to 10 minutes because Mary has a question here.
What is the best course of action for citizens to change current laws to make death with dignity available to more patients?
Okay, that sounds like one we should start with Cassandra and then move on down the table. So Cassandra?
I would say start by trying to write your senator about the law that we're passing right now. Stay involved in advocacy efforts and talk to your communities of what you would like to see changed in this law. The United States, in my personal perspective, is pretty far behind other countries that are doing this, and there's a lot of room to grow, and maybe not necessarily the political movement right now to do it.
Okay, Dr. Jones, any comment? Okay, Sandy? Paul?
I would just say if the state changes it to allow advanced practice clinicians to participate, that'll increase the number of possible providers 2 to 3 to 4-fold.
Okay, and I just remind you that in Cassandra's presentation, she said there was a current bill pending, ESHB 1141. So if you want to have an immediate action to advocate in Olympia, that's a bill you can talk about. Okay, and we're going to take one more question over here, and then we'll conclude.
Okay, so this question comes for a medical assisted aid in dying. Are there drugs? And if there are drugs, what are they if you qualify? So what are the drugs that they're using in medically assisted, is what I'm hearing.
Cassandra, you want to start that question?
Yeah, so we've had about 3 or 4 different eras of different drugs. Right now, we use a regimen that is being used nationwide called BDMA-PH. It is a mixture of digoxin, diazepam, morphine, amitriptyline, and phenobarbital, which is all compounded medications that are used for other things in combination, put somebody to a deep sleep and then works to shut down their heart and respiration.
Okay, Dr. Jones, any comment? Sandy?
No.
Okay. Okay, so I'm going to go ahead and draw this to a close. I'd like each of the panelists just to give us one thought that you'd like all of us to take away from this discussion. So we'll start with Paul.
Talk to your loved ones about what's important to you.
Okay, Sandy?
Talk to all the people you care about, not just your loved ones. All the people who care about you, because I don't know if you know this, but 25% of seniors over the age of 65 have no one. So it's the people who care about you.
Yeah, and if you have a penchant for advocacy, this really is an area that the Washington state law needs to come into the 21st century, and we could use your help with that.
Okay, Cassandra?
I would just say I'm so glad you all showed up and took the time today, but don't pat yourselves on the back too much, because really the next step is making sure that you are having these conversations with folks and having these wishes documented. Just because it feels good to do this first step, you walk out more educated, but I've seen so many of this paperwork just stack up on tables and not actually get filled out, or these conversations aren't being had. So.
Thank you. And my concluding comments is that this is a community that has a lot of amazing resources. I want to thank the League for bringing some of them together, but there's more out there. One of the speakers, Phyllis Bernard, that couldn't be here, I was surprised to find out she's local. She has this amazing background. I thought she was coming in from DC to see us, but they said, no, she's local and belongs to the League. So the other person, someone came up to me today and showed me a book called The Last Journey, which is available at Port Book and News, and it's written by Lynn Keegan and Penny Sanders and Carol Ann Druick, and they're local. And in fact, Lynn is here. She's standing right there if you want to talk to her about her book. And so that I don't get a percentage of what she sells. But anyway, it's just nice to know that we do have some real expertise here in our community. And yes. Oh.
And with many, many patients. So
Okay.
we put this together, the last journey, to show all the steps. Cassandra talked about it, but we have it all in one place. Very reasonable choice of
Okay, thank you, Lynn. And Paul said he has one more comment to make.
One comment, I'm looking at this audience. Thank you for being here. You're all a little older than me in general. And I want to just point out that, in recent memory, I'm old enough and from Central Jersey, Karen Ann Quinlan was a young woman. And then more recently, Terry Schiavo was a young woman. So talk to your kids. Everyone needs advanced directives and everyone needs a surrogate decision maker, because you never know. So this is not only for those of us with gray hair. Thanks.
Okay, and thank you again for coming. Thank you, Cassandra. Sorry the ferry didn't get you here.